Hello, I'm Gabriel Stegg from Hôpital Bichat in Paris. Let's review together a clinical case of STEMI. This is a 78-year-old male who calls emergency services for prolonged chest pain. The patient has a prior history of smoking, type 2 diabetes and hypertension, and chest pain started approximately an hour and a half ago. The patient lives approximately 20 minutes from a PCI hospital in a big town. Emergency services have dispatched a mobile intensive care unit which arrives at the patient's home 18 minutes later. Upon arrival, there is persistent, strong and intense chest pain. Blood pressure is 185/92. Heart rate is 105. There are no RALs or signs of heart failure. An EKG is done 8 minutes later and shows clear ST segment elevation in leads D2, D3, VF, V5, V6 with ST depression in the anterior leads. Which reperfusion strategy would you select and which antithrombotic therapy would you implement and when? First, it's important to remind ourselves that the diagnosis has to be done within 12 minutes of first medical contact, which was the case in this patient because it was done 8 minutes after medical contact. The second issue is the selection of reperfusion strategy. The patient did not present at a primary PCI capable center. The patient presented in the emergency medical setting. And here the question is, are we able to implement primary PCI within 120 minutes of first medical contact? The answer is clearly yes. The patient lives 20 minutes from a PCI capable hospital and therefore should be transferred immediately for direct primary PCI, bypassing the emergency room. So the patient indeed was dispatched bypassing the emergency room and was transferred for primary PCI. The second question is, which antithrombotic therapy should we implement while transferring the patient? There are various options. The option we usually use in our setting is a combination of aspirin, starting with a loading dose of 250 milligrams IV, followed by 75 milligrams per day orally, an ADP receptor blocker, and our preferred choice is ticagrelor with an 180 milligram loading dose, then 90 milligrams BID, and an anticoagulant using bivalirudin with a loading and infusion dose. These choices are based on clinical trials and the guidelines. Aspirin has clearly demonstrated benefit in patients with acute myocardial infarction. Clopidogrel has also demonstrated benefit. Do we have any reason to prefer the novel ADP receptor blockers? Well, prasugrel has been compared to clopidogrel in the Triton trial for patients who are going on to primary PCI and has shown a reduction in the primary outcome event of CV death, MI, and stroke at the expense of some increase in bleeding. The effect was homogeneous for patients with non-STEMI and STEMI, but importantly, in the subsets that were looked at in a post-hoc fashion, patients with a prior stroke or TIA, an age above 75 years, or body weight below 60 kilograms had an excess bleeding rate that resulted in no net clinical benefit, and therefore these patients are generally considered poor candidates for prasugrel. The other novel ADP receptor blocker is ticagrelor, which was compared to clopidogrel in the Plato trial and also showed a approximately 20% reduction in the same primary outcome. Importantly, in Plato there was a mortality benefit. The benefits appeared also homogeneous regardless if the patients had STEMI or non-STEMI. Finally, with respect to anticoagulation therapy, the reason for selecting bivalirudin is based on the results of the Horizons AMI trial, which showed that compared to a combination of fractional heparin and a GP2B3A blocker, bivalirudin reduces mortality, and this mortality reduction is sustained up to 3 years. These choices are consistent with the guidelines, which indeed recommend aspirin and an ADP receptor blocker for everybody, with a preferred choice of prasugrel or ticagrelor, prasugrel being restricted to clopidogrel-naive patients with no prior history of stroke or TIA and an age of less than 75 years of age. You'll remember that in our case, the patient is 78 years of age and therefore is not a good candidate for prasugrel. Ticagrelor is therefore a logical choice, and the guidelines highlight that clopidogrel should preferably use when prasugrel or ticagrelor are either not available or contraindicated. With respect to anticoagulation, the guidelines highlight that an injectable anticoagulant must be used in primary PCI. Bivalirudin is the third choice with the grade 1B recommendation, with the use of GP2P3 blockers restricted to bailout, and it's preferred over a combination of fractionated heparin and GP2P3 blocker. Enoxaparin, with or without GP2P3 blocker, may be preferred over fractionated heparin. And finally and importantly, if patients have received neither bivalirudin nor enoxaparin, then they must receive fractionated heparin. So our patient has undergone primary PCI and an emergency angiogram, and the angiogram has shown a total occlusion of the right coronary artery with TIMI-0 flow, diffuse lesions in the left circumflex, and tight lesions in the proximal LAD and first diagonal. What should be our policy with respect to primary PCI? Well, the guidelines indicate that the patient should undergo primary PCI with stenting of the culprit vessel, and that outside of cardiogenic shock, there is no reason to embark on early revascularization of the non-culprit vessel. If performed by an experienced operator, the radial access should be preferred over femoral access, and indeed, our patient had an angiogram via the radial access. And finally, if the patient has no contraindication to prolonged dual antiplatelet therapy and is likely to be compliant to therapy, drug-eluting stents should be preferred over bare metal stent. And that is exactly the therapy that our patient received. The patient did undergo stenting with a drug-eluting stent of the culprit vessel. TIMI-3 flow was reestablished early within the delays that are recommended, and subsequently the hospital course was uneventful, and the patient underwent elective subsequent angiography with revascularization of the LAD lesion. Now, the hospital course was uneventful, and discharge was planned 72 hours after admission. The next question would be, what would be your discharge prescription with respect to antithrombotics, and what would be the duration of antithrombotics? Well, our routine practice would be to discharge this patient on dual antiplatelet therapy, combining aspirin at a low dose, 75 milligrams per day, indefinitely. And we would add to that an ADP receptor blocker, and having chosen ticagrelor in the acute phase, we stick to the same agent, ticagrelor 90 milligrams BID, for up to 1 year. There is no indication for chronic anticoagulation therapy in this patient. Now, is there any reason to continue ticagrelor rather than clopidogrel, given that we are beyond the acute stage where the thrombotic risk appears greatest? Well, indeed there is. Based on the results from the Plato trial, the clinical benefits, in particular on the primary outcome, but also on cardiovascular mortality, appear to accrue over time, so that the longer the therapy, the greater the benefits. And despite the absolute increase in risk being greatest in the acute stage, there are continued benefits to continued therapy up to 12 months. And this is indeed also consistent with the guidelines for management in the subacute and long-term phase of STEMI, which do recommend dual antiplatelet therapy for up to a year, and 12 months is actually the recommended duration of therapy. Now, recognizing that in many patients there are procedures or events that may require withholding dual antiplatelet therapy prematurely to that 12 months duration, the strict minimum is 1 month in patients with a bare metal stent and 6 months in a patient with a bare metal stent, with a drug-eluting stent. And our patient, having had a drug-eluting stent, has a strict minimum of 6 months and a recommended duration of 12 months for dual antiplatelet therapy. Had the patient had an indication for oral anticoagulation, then there would have been no reason to combine a novel ADP receptor blocker with aspirin, and that patient should preferably have received clopidogrel with aspirin for the shortest possible duration in order to minimize bleeding. I hope you've enjoyed this clinical case. For further information, I refer you to the ESC website, which has the full text and slides of the guidelines, as well as to the very useful pocket version of the guidelines and even smartphone version of the guidelines. Thank you.